Chapter 19, gram-positive bacilli of medical importance. We did gram-negative last week. The last time we'll do gram-positive this time. So, medically important gram-positive bacilli can be subdivided into basically three general groups. That's determined by the presence or absence of those endospores and acid facets, how it stains with acid dyes, and whether it goes into endospores or not, into the capsules. So there's three general groups. There's endospore formers, non-endospore formers, and then the irregularly shaped and staining properties. So first group, the endospore formers, okay? Aerobic or facultative anaerobes, they're bacillus, or the obligate anaerobes, which are Clostridium. And your non-endospore formers, their second group, they're regular shape, okay? Listeria, erysipelathrix. And the irregular shape and staining properties is your third group. You have non-acid fast and acid fast and filamentous branching cells. So the non-acid fast are Corynebacterium and Propionibacterium. The acid fast ones is Mycobacterium. And the filament branching cells, Actinomyces and Nocardia. And we're talking about all those coming up here. So basically the endospores we talked about before. Endospores are a dense surviving unit that develops in a vegetative cell in response to nutrient deprivation. So the bacteria is growing along and all of a sudden its nutrients run out. Rather than dying off, it seals itself and basically hibernates. It shuts everything down, forms a spore, which is very hard to kill, very resistant, and it exists until nutrients appear back in the area. So it can propagate again. Okay? That's why our tests for like dental equipment, things like that, when we test for sterility, we have to do a spore test. We have a little package of spores, we put in our sterilizer and we run it with that. And if it kills the spores, you know it's going to kill everything else. Because the spores are the hardest thing to kill. So most endospore form bacteria are gram-positive. They're model and mobile, they can move. Rod-shaped forms in general bacillus and cladistrium. They're resistant to heat, drying, radiation, and chemicals. Okay? So they're really hard to kill. They're factors for survival, longevity, ecological niche, finds when the nutrients come back, and pathogenicity of spore formers. Okay? So this is your gram-positive spore form bacilli. This is a vegetative cell right here. You can see the bacterial cell. And this is the spore that forms inside of it. Kicks off here. And all you got is this little spore that hibernates. Okay, and waits for an opportune time to come back out again. Same thing here. This is a little different shaped ones. You can see the spores forming inside here, inside the cells. This is your vegetative cell, and then it forms a spore inside of it for the endospore. General characteristics of the genus Bacillus. They're gram-positive, endospore-forming motile rods. Mostly saprobic, which means they can live without a little bit of oxygen. Aerobic and catalase are positive for test results. They're versatile in degrading complex macromolecules. They're a source of antibiotics that are produced. Their primary habitat is they live in the soil. And there's two species of medical importance. There's Bacillus anthracus, which causes anthrax, and Bacillus cereus, which causes one type of food poisoning, like botulism. It's a type of food poisoning. So the Bacillus anthracus is large, block-shaped angular non-motile rods, about 3.3 to 5 micrometers long, okay, and 1.2 roughly micrometers wide. Their central spores develop under all conditions except in the living body. In the living body, you have a constant supply of nutrients. You don't develop spores. Okay? The virulence factors is the polypeptide capsule, and exotoxins are produced. Exotoxins cause edema and cell death. So they protect the bacteria. They protect the bacillus. And we saw the picture before. This is the vegetative state here. This is the spores as they form in these polypeptide chains there. The majority of Africa, Asia, and the Middle East. Okay, there's three types of anthrax. There's cutaneous, pulmonary, and gastrointestinal. And this is where they occur. Cutaneous, the spores enter the skin. The black, sore, eschar, they're the least dangerous of the three. Pulmonary is inhalation of the spores from animal products or from the soil. And gastrointestinal, we ingest it. And these are very rare, and this one is lethal. Okay. Control and treatment of anthrax is treated with clindamycin, doxycycline, and ciprofloxacin. Okay. Antibiotics are given along with the second drug, raxibacumab. This also uses monoclonal antibodies that bind one of the toxins and prevent its entrance to the cell. So it's a two-step treatment with it. We use the antibiotic and we use raxibacumab, okay, which stops it from getting into the cells. So the antibiotic kills it, the other one stops it from entering. It's a two-step attack. Vaccines to anthrax, okay, live spores and toxoid to protect the livestock. So we do have vaccines to anthrax. We use live spores, toxoid, to protect our livestock. Purified toxoid is biothorax for high occupations, military personnel, anthrax attacks, which we referred to before in the past. Toxoid is 6 inoculations over 1.5 years, and then an annual booster every year. So it's a lot to keep vaccinated to anthrax. That's just only used basically military and high-risk groups. Bacillus cereus is a common airborne and dustborne. Usual methods of disinfection and antisepsis are ineffective. It grows in foods. Spores survive cooking and reheating. Ingestion of toxins contains food causes nausea, vomiting, abdominal cramps, diarrhea. Usually lasts about 24 hours. There's no treatment for it. Just keep the patient hydrated, treat the symptoms, and increase and report in immunosuppressed patients. So if you have a suppressed immune system, it's going to be more common, more easy for this bacteria to invade. And that's the food poisoning. Genus Clostridium. Clostridium is also a gram-positive. It's a spore-forming rod. It's anaerobic and catalase negative. It does not produce catalates to destroy cells around it, and it is anaerobic. Okay, just lives without oxygen. There's 120 species with oval and spherical spores, produced only under anaerobic conditions. Synthesizes organic acids, alcohols, and exotoxins, used to prevent its destruction. Causes wound infections, tissue infections, and food intoxicants. Right. This is Clostridium, and this is the spores that form inside the vegetative cell when it's deprived of nutrients, so it can go into a spore, so it's a non-active state. Okay, so gas gangrene, this is a nasty infections, myonecrosis. So Clostridium perfringens is the one that causes it, it's most frequent. Clostridia involved in soft tissue and wound infections. These are spores found in soil, in the human skin, in the intestines, and the vagina. Okay. Predisposing factors for getting gangrene, okay, are surgical incisions, compound fractures, diabetic ulcers, septic abortions, puncture wounds, and gunshot wounds. Okay, in all those cases, a lot of infections can travel with that factor into the wound. Virulence factor, how virulent is it? It produces an alpha toxin, which red blood cells rupture, causes edema and tissue destruction, causes collagenase to be produced, which destroys your collagen, hyaluronidase, which destroys soft tissue areas, and DNase, which affects DNA. So it's very virulent, very disruptive bacteria. Okay, it causes severe damage in the human body. And when you see the muscle fibers here, in the muscle fiber, you have these gas-filled spaces. Remember, gas gangrene is that it starts to infect the tissue and it forms gas. It forms these actual air pockets inside your muscles filled with gas. And when you get gangrene, gas gangrene, you can smell it. You can identify your patient as soon as they walk in the waiting, as soon as they're in the hospital room, wherever you walk into, you can smell gas gangrene. It's very distinctive. There's two forms of gas gangrene. Okay, there's an anaerobic cellulitis, which is inflammatory cells under anaerobic conditions. Bacteria spread within the necrotic tissue, produce toxins and gas, but the infection remains localized. It stays in the area, in the foot, in the hand, wherever the infection was. True myonecrosis, okay, is more destructive. It's extensive, mimics some aspects of necrotizing fasciitis. Okay, remember planes of fascia, remember your anatomy? Planes of fascia spread throughout the body around all the different muscle areas like that, so it spreads throughout the body. So this is myonecrosis, can spread on those fascial planes and cause tremendous destruction. It's spore germination, it's vegetative growth, and release of virulence factors. Fermentation of muscle carbohydrates results in the formation of gas, and further tissue destruction. And that goes throughout the body. It is not localized. And that's what gas gangrene can look like. It's extremely nasty. You see the incision, the surgical incision that was made beforehand, or a puncture, whatever that was, but it stitched it up. But the infection was still inside there, and gas gangrene got on. A lot of times with gas gangrene, you have to amputate the limb. Okay, there's no way to save it. It is not a very treatable disease. Okay. Treatment and prevention of gangrene: immediately cleansing of the dirty wounds. Deep wounds have to get them cleaned out. Compound fractures or infected incisions all have to be cleaned out. Debridement of diseased tissue, so all that black tissue so far has to be cleaned out. Large doses of cephalosporin or penicillin. Hyperbaric oxygen therapy. Okay, hyperbaric oxygen is you put yourself in a chamber and you seal it up and you increase the amount of oxygen and you increase the pressure of oxygen around the whole body. So remember, this is an anaerobe that grows. So increase the oxygen, it absorbs oxygen into the tissue, into your body, and helps kill anaerobic bacteria and kill off the gas gangrene by exposing it to high pressures of oxygen inside a hyperbaric oxygen chamber. Okay. That's what we use in treating like the bends for deep sea divers. We use hyperbaric oxygen here for the oxygen into the bloodstream. And there are no vaccines available for gaseous gangrene. Okay, that's a hyperbaric oxygen chamber. Seal the patient in there, increase levels of oxygen. So you get high concentration of oxygen permeating the body. So which of the following is the mode of transmission for Bacillus cereus? Bacillus cereus, so let's go back and see where Bacillus cereus was. Shouldn't be too far back.
Ingestion through food?
I believe it was. Bacillus cereus grows in foods, spores, surviving cooking and reheating. It's your form of food poisoning. Okay, so it enters through
B.
Ingestion, right? Very good, perfect. Tetanus. Tetanus is another one. We have a vaccine for tetanus that we usually give, especially young kids, or anytime you're exposed to environments where there's dirty metal, dirty nails, possible punctures, things like that. Tetanus is a very, very quickly advancing disease. It's also called lockjaw. It's a neuromuscular disease. Okay, it's referred to as lockjaw due to infections of the disease of the muscle. It clamps down, causes all the muscles of the body to contract. And you see some picture where it can actually contract the muscle so hard you can actually break your spinal cord from the contraction of the back muscles as you flex backwards. You can't treat it once you have it. You have to treat it with the vaccine beforehand. That's why it's important to have it. It's produced by Clostridium tetani. Okay, cultivated soil. It's found in the gastrointestinal tracts of animals. The spores usually enter the body through an accidental puncture, like a wound, burns, umbilical cord, frostbite, or crushed body parts. Okay, it's an anaerobic environment. It's required for vegetative cells to grow and release the toxin. Okay, so tetanospasms. The neurotoxin causes paralysis by binding to the motor nerve endings, blocking the release of the neurotransmitter for muscle contraction inhibition. So muscles contract uncontrollably. Death most often due to paralysis of the respiratory muscles. So what happens is you have your muscular joint, acetylcholine is released into that joint. That causes the release of calcium into the joint, and that causes the nerve to propagate and cause the muscle to contract. So you have your nerve running down, and your nerve comes down to innervate your muscle tissue, and it releases acetylcholine. ACH gets released, and the muscle, like I said, it causes the calcium release from the little sacs, causes the muscle to contract with ATP. Okay. Now you have an enzyme that ACTase, okay, acetylcholine esterase, that stops ACH. Because once your muscle contracts, you gotta stop it. You gotta be able to contract it and uncontract it. You can't keep it contracting. So the acetylcholine esterase is released into the nerve ending, okay, and it absorbs up the ACH and the muscle relaxes. Okay, what tetanus does is stops the acetylcholine esterase from working. It blocks it. So now you have nothing that's going to stop the acetylcholine. So acetylcholine continues to stimulate and stimulate and stimulate the muscle, and the muscle just fully contracts, and you can't release it. So every muscle in your body contracts. So extremely painful. Your jaw locks shut. That's why they call it lockjaw, because your jaw clamps shut. Your fingers contract. Every muscle in your body contracts. Okay, not a nice way to die. Now, this is the most common among geriatric patients, IV drug users, because it's very interesting tetanus. Neonates in developing countries, neonatal tetanus. Now look at the person's back. You can see this contraction here. You can see that flat, that contraction is gonna, like you can contract hard enough to snap your spinal cord when tetanus occurs. It just, yeah, it is a nasty disease.
So the ACH is what causes the muscles to contract, and then when you have tetanus, there's nothing to stop that ACH from producing.
Right, because you have the, here's your nerve, it comes down here. Okay, and then it goes to your muscle tissue. And muscle tissue has a
Myelin sheath.
actinomycin,
Oh.
contract, right? The muscle that pulled to contract it. So ACH is released, okay, from here, and it goes into this neuromuscular junction, okay? Causes the muscle to contract. ACHE, acetylcholine esterase, is released and eats up the ACH. So the muscle stops contracting. It stops stimulating the receptors on the muscle. Now the ACH isn't around anymore because the tetanus destroys the ACH, that's when it attacks. So the ACH sits in the joint, causes the muscle to contract over and over and over, causes a constant contraction and nothing to stop it. And it's just, I mean, all your muscles in your diaphragm contracts and stops. Never relaxes. You can't breathe in. So you suffocate because you can't breathe. Your heart contracts and it can't keep beating. Every muscle in your body contracts.
Wow.
And
So
it's
pretty much
extremely, what's that?
so like pretty much once you get it, there's nothing you can do about it.
Right, but the vaccine stops it.
Yes.
And then the booster every 5 years, I believe, was tetanus too.
Wow.
Okay, so it's treatment aimed at deterring degree of toxin and infection and maintain the homeostasis, maintain the regular body condition. So the antitoxin therapy with human tetanus immunoglobulin inactivates the circulating toxin, but does not counteract that which is already bound. Because you gotta get it before it binds in there. Control infection with penicillin, tetracycline, and muscle relaxants. You can try, but the vaccine is the best way to treat it. Okay, boosters need every 10 years, every 5 years. So you get the vaccine every 10 years, you get a booster. Especially you lived in areas where there's a lot of construction, a lot of animal feces in the soil, usually rusty nails, things like that can puncture the skin, can transmit tetanus. But yeah, it's not a fun way to die. Clostridium difficile infection, clostridial diseases, most commonly called C. diff infections, or CDIs, are the second most common intestinal disease after salmonella in industrial countries. Caused by Clostridium difficile, it's a normal resident of our intestines, but it's usually in low numbers. Produces enterotoxins that damage the intestines. Major cause of diarrhea in hospitals, because in hospitals, remember, we're treating patients. We're giving them antibiotics, we're giving stuff to treat other infections, right? So we're killing off the bad bacteria along with the good bacteria. So the good bacteria die off. This is opportunistic and it starts to grow in numbers. So this is, you get diarrhea produced in hospitals because you're killing off the good bacteria, and this can now take its place. This can now grow in the place where the good bacteria was growing. Right? So it's increasing, it's common in community-acquired diarrhea where it's spread throughout the community. Yeah. Antibiotics associated colitis. Okay, when you take antibiotics, like you said, we kill off the bacteria we want, but also kill the good bacteria, and that can cause colitis, which is another intestinal disease. Relatively non-invasive treatment with broad spectrum antibiotics kill the other bacteria, allowing Clostridium difficile to overgrow. Mild cases respond to fluid and electrolyte replacement, because when you get bacteria or you get diarrhea, there's nothing being absorbed, everything's coming out. So you're going to dehydrate. So you've got to get plenty of fluids, electrolyte replacements, and then when you get rid of the antibiotics you're treating with once the infection is gone. So your infection is treated with oral vancomycin or metronidazole and replacement culture. So you actually take the good bacteria and put it back into the system, your probiotics. Okay. So here's your intestine. This is a healthy intestine, what it looks like here. And you can see Clostridium difficile is developing on the intestinal walls here. This destroys the intestine. and it can't absorb the food, so you just get diarrhea. No absorption, dehydration, lack of electrolytes, all that good stuff. So Clostridial food poisoning. There's 2 Clostridium species are involved in food poisoning. Clostridium botulinum, it causes botulism, and Clostridium perfringens. The botulinum is rare but severe intoxication, usually from home canned foods, so we usually get that one. Okay. Perfringens is a mild intestinal illness, second most common form of food poisoning in the entire world. So botulinum food poisoning. Botulism is intoxication associated with inadequate food preservation. The food spoils. Clostridium botulinum is spore-forming anaerobe, commonly inhabits soil and water. Spores are present on food when they're gathered and processed. If reliable temperature and pressures are not achieved, air is going to be evacuated, but the spores are going to remain. Remember, the spores can grow as that nutrients are there. So anaerobic conditions favor spore germination and vegetative growth. So you suck everything out, suck all the out when you're processing it. If you don't get the spores out with it, which is not always anything new, they're gonna grow in anaerobic conditions, and there's plenty of food for them now. It's a very potent toxin. Botulism toxin is released. One of the most deadly toxins that we have. Okay. Botulism toxin is carried to the neuromuscular junctions and blocks the release of acetylcholine. Remember what acetylcholine does? It causes the muscle to contract. So now we have the exact opposite of tetanus. Muscles can't contract. Okay. So you get double or blurred vision, difficulty swallowing, neuromuscular symptoms where your muscles don't work. If that affects the diaphragm muscle along with it, you die suffocation. Because the diaphragm has to contract to pull forward, allow air in, and then relax, allow air back out. Okay. Extremely deadly toxin, and that is what Botox is. That's what people inject in their faces all the time. What it does, it blocks acetylcholine. Okay. What causes wrinkles? Wrinkles are caused by muscles contracting. They pull the skin tighter and cause wrinkles. So this blocks the acetylcholine that blocks the muscle from contracting. Acetylcholine release, so the muscle can't contract, so you don't form wrinkles. So it paralyzes the muscles of your face. It usually lasts 6 months or so.
So isn't that bad to get that when you're young then? Because
I don't think it's great to get at any age, to be honest with you.
no,
It's a nasty toxin. It's one of the most powerful toxins we know of.
but what if you're just injecting it like, underneath the epidermis where
Right.
like dermatologists do?
Right.
Why do
But,
we do it so much then?
but who's allowed to inject Botox? Does it have to be a physician?
RNs and
Parents can do it.
RNs and yeah, I think you have to be a licensed nurse actually to inject it, or a doctor.
Different states have different rules.
Mm-hmm. California, I know you have to be an RN or a doctor.
Right. Florida, they used to use spas could do it.
Yeah, estheticians used to be able to
That's right.
out here, and then they got that.
You got people. I'm still some say I don't know the rules of all the states, but that's an extremely toxic material. That's it's a very potent toxin.
It's
So-
very interesting because it has to get released, I think, through the bloodstream, right? Eventually, if you're injecting it to your skin.
If your keyboard's going, does not get in the bloodstream. You don't want it in the bloodstream. Then it can travel. Okay, it's subdermal injection, but it does not go into the bloodstream. You want to stay localized in that area for 2 reasons. One, you don't want to go to the rest of the body to cause its effects, which can be fatal. And secondly, you want it to work in the area you're only injecting it in. Okay, if you're injecting it like above for the forehead to give you no wrinkles in your forehead, then you don't want to get in the eye and cause paralysis of the eye. There's been a lot of cases where you have drooping of the eyelids where they inject either the wrong place or it's traveled, and the patient can't see for 2 to 3 weeks because the eyelid completely closes down. You can't lift it. There are some medical uses for it, migraines, things like that. We do use medical uses for it, and if you inject it right, it can be used. But I think it's an abused drug in our society. But that's just my opinion. But if it's done right, it's safe. But if not done right, it can cause problems. It's a very, very strong toxin. I'll have to look. I'll see if there's been any cases recently of any problems. Note here to do that. But here's your botulism. This is your motor input. This is your nerve conduct. Here's your action potential. Your nerve travels down here and releases ACH across the cells. This is a neurosynaptic neuromuscular junction. Okay, the acetylcholine comes out of these little grooves, out of these little vesicles, travels across, and causes the muscle to contract. These muscle fibers, the actin and myosin contract and cause the muscle to contract. So this stops the ACH from coming out of the vesicles. So this neuromuscular junction has no ACH in it. So it can't contract, so the muscle can't contract, so the wrinkles go away because the muscles don't pull. So infant and wound back to botulism, it's caused by ingesting spores that germinate and release the toxin. Okay? Botox, this is a toxin. Most common type of botulism in the United States, with about 80 to 100 cases every year. Okay? Immature state of neonatal intestines and residential microbial allow the spores to gain a foothold, germinate, and produce neurotoxin before the baby has a chance to develop an intact intestinal tract. Results in baby flaccid paralysis, which is called floppy baby syndrome, where the baby just can't contract any of the muscles. Now, wound botulism, the spores enter a wound and cause food poisoning symptoms. Increased causes for botulism reported injecting drug users. Okay, using contaminated needles, they get the spores entering through the injection, and it causes food poisoning symptoms. Treatment and prevention of botulism: determine the presence of the toxin in the food, intestinal contents, or in the feces. Administer the antitoxin, cardiac and respiratory support. Remember, your heart is a muscle, and your breathing diaphragm is a muscle. Okay, if you have botulism into the bloodstream and it starts to affect the heart's not going to beat. The respiratory system, you have respiratory collapse. Okay, infectious botulism you would treat with penicillin. Practice proper methods of preserving and handling canned foods, and addition of preservatives when you're canning your food to prevent botulism. Clostridial gastroenteritis caused by Clostridium perfringens. These are spores contaminated food that have not been cooked thoroughly enough and does not destroy the spores. Remember, when you're cooking food and everything else, you're cooking it to destroy the spores, not just the bacteria. The live bacteria, once it's being cooked, it goes into these little spores. Those spores are hard to kill. So spores germinate and multiply, especially if the food's left unrefrigerated. Because it's warm, it can be multiplied quicker. When consumed, toxin is produced in the intestines, acts on the epithelial cells of the intestine, causing acute abdominal pain, diarrhea, and nausea. But then you get rapid recovery as your immune system works. So the differentiation of spore-forming species, this is just a different requirements, which we talked about. Basilicus anthrax, okay? Cutaneous anthrax and pulmonary anthrax and gastrointestinal anthrax are the different types. The cutaneous, we do with antibiotics. The pulmonary, we have vaccines for very high-risk patients, like we said with the military, going into combat areas. And gastrointestinal is also antibiotics. Food poisoning goes through Bacillus cereus. Okay, there's no treatment for it, but it's a self-limiting disease. It works as well. These are support the symptoms. Keep your patient hydrated, and keep the electrolyte balance up. Clostridium perfringens. This is very strict anaerobe, anaerobe conditions. Gas gangrene. That's when the treatment is oxygen therapy, hyperbaric oxygen chamber. We get to breathe it. It's treated extremely. That's where I'm looking for. We do it extremely quick, and we pull out all the stops, clean it out, antibiotics, oxygen chamber, the whole bit. We hit it with everything because it is going to spread and it can be fatal. The perfringens can also cause food poisoning, which is usually mild. No disease is also self-limiting, but the gas gangrene is a dangerous one. Clostridium difficile is an antibiotic-associated colitis. Remember, you killed off all the bacteria, which meant the good bacteria. So this bacteria here can invade those areas and start to grow. So you get rid of the antibiotics and you administer probiotics. And you can actually put microbiota back into it with transplant, fecal transplants. Clostridium tetani, that was tetanus. Vaccine was our passive immunization. Botulism again is we use the antitoxin. particularly against botulism. Okay. The action of botulism toxin is on the spinal nerves, the cerebellum, the neuromuscular junction. The smooth botulism toxin affect
Is
the
it
body.
the neuromuscular junction
You
or the
got it. The neuromuscular junction. It prevents the release of acetylcholine into the neuromuscular junction.
I don't know why I wanted to say smooth muscle as well though, but I felt like but it's the yeah.
The neuromuscular junction for smooth muscle. It's usually a skeletal muscle that it affects. But it's definitely the neuron because it stops ACH, acetylcholine, from being produced. Not being produced, but being released from the vacuoles into the neuromuscular junction. So the muscle can't contract. And you're right, neuromuscular junction. So a gram-positive, regular non-spore forming bacilli now. They stain uniformly, do not assume pleomorphic shapes. They have different shapes there. Medically important to Listeria monocytogenes and Erythropelothrix rupiopathy. Okay, Listeria monocytogenes, non-spore forming, gram-positive. The coccibacilla, they relate from the coccobacilla from circulars to long filaments. They have 1 to 4 flagella and they lack a capsules. The resistance to cold, heat, salt, pH extremes, and bile. Their verse is attributed to the ability to replicate in the cytoplasm of cells after inducing phagocytosis. So they get the cells to engulf them, and once they're inside the cell, then they replicate. This avoids the humoral immune system. Once the cell eats it, it's not exposed to the B cells and T cells anymore, right? Because those circulate the antibodies through the bloodstream looking for them. So once they've been induced by phagocytosis by the other T cells, they're inside. Once they're inside, the immune system can't touch them. So then they do their thing. So here they are in bloodstream. They go inside the cell. They go in the cell. They trick the cell into producing more of them. And then they release the cell and infect another cell. The epidemic of pathologies of listeriosis, primary reservoir is soil and water, okay, and animal intestines. They can contaminate food and grow during refrigeration. Listeriosis, in most cases associated with dairy products, poultry, and meat, often mild or subclinical in normal adults. Okay. Immunocompromised patients, fetuses, neonates. It affects the brain and the meninges, 20%. So 1 out of 5 are going to die. 20% death rate. It affects your brain and meninges. Remember, there's 3 layers to your meninges that protect your brain. There's the dura mater, which is the one on the outside. There's a arachnoid. And then there's a pia mater on the inside. Those are your 3 layers of your meninges that help protect the brain. It affects those and can cause all kinds of problems with the brain.
What layer does meningitis affect? All the layers?
Yeah, meningitis affects all layers because it gets in there and it's an infection of the meningeal tissues. So it gets, the dura mater is a thicker one. The arachnoid matter is kind of medium, and the pia mater is like a cellophane that goes over the brain. So it gets in between there, it gets in between the arachnoid mater and the pia mater, and can penetrate directly into the brain tissue. Like the pia mater is just like if you ever dissected the brain anatomy, you got that real thin, filmy stuff over the cerebral cortex, and that's your pia mater. It's just like saran wrap. It's really thin and transparent. But it gets right in, and then it can go through the pia mater and go right to the brain. Okay, diagnosis and control of listeriosis. Culture requires lengthy cold enrichment process. Remember, it grows in refrigeration. So it's a cold process, and that's where it grows. Rapid diagnosis test, like Elisa we used before, immunofluorescence and DNA analysis. We've gone through all those tests. Ampicillin and trimethoprim are used to treat it. Prevention is pasteurization. Pasteurization of milk and dairy products and cooking. Okay, Erythropelothrix is gram-positive rod, widely distributed in animals and the environment. The primary reservoir where it lives is the tonsils of healthy pigs. That's where you find it. It enters through skin abrasions, multiplies to produce erythrospleloid and dark red lesions, penicillin, erythromycin, and a vaccine for the pigs is used to treat it. You can see the red areas here, the bands that it creates. So gram-positive irregular now. non-spore forming bacilli. They're irregular, so they're pleomorphic, many shapes. They stain unevenly. The stain doesn't affect it like it does all the other ones uniformly. Medically important genre of them is the Corynebacterium, Mycobacterium, Actinomyces, and Nocardia. The Corynebacterium is straight. Diphtheria is straight or somewhat curved rod, taper the end with many pleomorphic variants, many different shapes and sizes. Reservoirs of healthy carriers, potential for diphtheria. Okay. Most cases are in non-immunized children that create crowded, unsanitary conditions, acquired via respiratory droplets from carriers from infected individuals. So it's respiratory droplets from infected individuals. That's what diphtheria looks like. This is a Palisades arrangement where they're grouped into long chain groups of the bacilli or pleomorphism, many different shapes you can see in different areas. There's two stages of the disease of diphtheria. There's local infection by Corynebacterium diphtheriae. The upper respiratory tract infection is a primary infection, sore throat, nausea, vomiting, swollen lymph nodes, and pseudomembrane formation can cause asphyxiation. Okay. Cutaneous diphtheria is a secondary infection. So primary infection is your lungs, your respiratory tract. Secondary infection is the skin. Okay. Diphtherotoxin production and toxemia. It targets the organs, primarily your heart and your nerves. Okay. This is the cutaneous form. You can see that is a huge lesion. Okay, on the cutaneous, and then it causes your sore throat. You see it back on the tonsillar pad area, and the uvula back here in the soft palate. This is your primary. This is your secondary. This is cutaneous. This is respiratory. Okay, diagnostic methods for it. The pseudomembrane is swelling. You diagnose with the pseudomembrane that you have that coats over like in the skin, and the swelling. Different stains, they cut the patient, get the condition, their history, and serological tests, blood screening tests and assays. Treatment and prevention is diphtheria antitoxin, penicillin, erythromycin. Prevented by the toxoid vaccine, you have a series, and then you have boosters. Okay, so diphtheria can be treated by the vaccine series and its boosters. Okay, now the genus Propynion bacterium, like Corynebacterium in morphology and arrangement, but it differs by being aerotolerant or anaerobic and non-toxigenic. Okay, so the Propionibacterium acnes is most common. That's a common resident of the pilosebaceous gland in humans, and this is what causes acne. The oily sebaceous gland is what it inhabits and causes acne to occur. So the Propionibacterium is occasionally involved in infections of the eye and artificial joints. So infection by the corneal diphtheria causes a pseudomembrane and respiratory disease. Okay, and can be prevented with a vaccine. True or false? Do we have a vaccine for diphtheria?
I think so.
Yep, we do. We just came back right here. Prevention of diphtheria prevented by toxoid vaccine, series and boosters. So presented by vaccine, that is true. Gram-positive, this is Mycobacteria, acid-fast bacilli. Gram-positive bacteria is irregular shaped, acid-fast staining, strict aerobes, they need oxygen. They produce catalase, destroy the cells around it, do not form capsules or flagella or spores. Okay, they grow very slowly. And that's what they look like. This is Mycobacteria. See the rod shapes there. Mycobacterium tuberculosis. Okay, this is what causes tuberculosis. Tubercular bacilli, long thin rods, grow into sinus masses or strands called cords. Produces no exotoxins or enzymes that contribute to infectiousness. Okay. The virulence factor contains complex waxes and cord factor that prevent destruction by lysosomes and macrophages. So it prevents the body from destroying it with our white blood cells. This is what these colonies or plaques inside your bodies and your lungs look like. This is the Mycobacterium tuberculosis. And these are the cord structures that they have. This is because cords or these waxes prevent our immune system from attacking it. So the white blood cells don't attack it and phagocyte and destroy it. Epidemiology and transmission of tuberculosis. Predisposing factors for tuberculosis include inadequate nutrition, okay, debilitation of the immune system, immunocompromised patients, patients with poor access to medical care, lung damage. And lung damage is a very common thing now with COVID. COVID attacks the lungs and leaves damaged scar tissues on your lungs, and genetics. It's estimated that 1/3 of the world population and 15 million in the United States carry tuberculobacillus, carry the bacteria for it. Highest rate in the US occurring in the recent immigrants have come in. Bacillus is very resistant, tuberculosis bacillus is very resistant, transmitted airborne respiratory droplets. 5 to 10% of infected people develop the clinical disease. So 5 up to 10% are actually have it. If untreated, the disease progresses slowly. Majority of TB cases are contained in the lungs. Clinical tuberculosis divided into 2 types, but divided into 3 types basically. There's a primary tuberculosis, okay, which is your initial contact, initial exposure. Secondary tuberculosis is a reactivation, reinfection after treatment, it comes back. Or disseminatory, which disseminated, which is extrapulmonary tuberculosis, which it goes outside the lungs. Okay. The infectious dose roughly is about 10 cells, which is not a whole lot. So it's very infectious with respiratory droplets. It's phagocytized by the alveolar macrophages, and once it's in there, it multiplies. After 3 to 4 weeks, the immune system attacks, forming tubercles. These are granulomas consisting of central core containing bacilli, surrounded by white blood cells. Again, those are called tubercles. In the center, the tubercle breaks down into necrotic, gaseous lesions. They gradually heal by calcification, calcify over. So they scar your lungs. This is the calcified lesion. This is what's in your lungs after exposure to tuberculosis. And you can see that part of the lung is not going to function. Okay. You can see those lesions in the lung tissue. Latent and recurrent tuberculosis. If a patient doesn't recover from the primary tuberculosis, reactivation of the bacilli can occur. That's the secondary one. Tuberculosis expand and drain into bronchial tubes and your upper respiratory tract. Gradually, your patient experiences more severe symptoms, violent coughing, greenish or bloody sputum, gets coughed up, fever, anorexia, weight loss, fatigue. If left untreated, tuberculosis will kill 6 out of 10. 60% mortality rate. Very, very nasty disease to treat. It's difficult to treat. You get exposure to tuberculosis droplets, it gets into your lungs. Okay. It can go to no infection in about 10-20% of the cases. Okay, and then you're fine. Or it can go to lung macrophages, they engulf it, they start to eat it, and then 80-90% of the cases, it will be a TB positive test. Okay. From there, the infection can be cleared up by the immune system and go back to TB negative test. Or you get primary tuberculosis disease, which is in the lungs. Symptoms occur 5 to 10% of the cases. It takes about 2 years. It's a long growing disease. After that, you can have, after you treat it, you can go to latency. The cell can go dormant in the lungs. Carrier state without symptoms may last for many years. You still test positive for tuberculosis. If it comes back again, recurrent disease, the tubercles break down. The white tubercles you saw in the lung tissue break down. Bacilli reach in the lung cavity and start with circulation again. Again, positive tuberculosis. Once that's done, it can go in infection and it can clear up. That can be positive or negative treatment. Or the disease can spread to extrapulmonary sites. It can spread throughout the body, like kidneys, bones, brain. Severe morbidity, 60%. So that's the flow chart of how tuberculosis can be infected. You can go from the lungs, primary infection, treat it. You can lay latent, reoccurrence, it can be treated again, or it can go into extrapulmonary tuberculosis. So during the course of reactivated tuberculosis, after the primary tuberculosis, the bacilli disseminate to the lymph nodes, kidneys, long bones, genital tracts, the brain, and meninges. These complications are extremely grave. Patients usually do not survive that. once that tuberculous bacillum has disseminated throughout the body. Clinical method of detecting tuberculosis. Okay. Immunological testing, okay, in vivo, which is called the Mantoux test. This is local indermal injection of purified proteins, PPD. And that's what you get when you go to the doctor. They give you that little stick with the little prongs. They inject the purified protein under the skin. Look for a red wheel to form in 48 to 72 hours. It's red again in 3 days, 2 or 3 days. Step is going to indicate interpretation based on the size of the wheel and specific population factors. It can also be detected by in vitro TB tests. Center for Disease Control has accepted 2 new indirect methods for blood tests: quantiferon TB, gold test, and T-spot tuberculosis test. These are blood tests for tuberculosis. Chest X-rays, non-diagnostic, but they're used out to rule out pulmonary TB. You can see it on chest X-ray. I'll show you a picture in just a second. Acid-fast staining of the sputum or the specimens, the Zeal-Nelson stain or the Flenson staining. Culture isolations and biochemical testing provide your most accurate diagnosis of what type it is you grow in the petri dish in the lab. This is you get an injection just under the skin. This is your subdermal. Sometimes you use a little thing with multiple prongs they push on your skin. So you use a small needle, inject it just under the skin, inject the proteins under there. It sits under there, and in 2 to 3 days, it grows, and it gives you different categories. 5 to 9 millimeters is category 1, 10 to 14 millimeters is category 2, and 15 millimeters is category 3. So you get the differentiation of the tuberculosis test. Very simple to read. You can see it in the lungs here. See all these things in the lungs. You can see starting in both lungs right there. You can see it. This is a fluorescence testing, the fluorescence test. You can see it glowing. It bounds with tuberculosis and bacteria bacilli. Okay, management and prevention of tuberculosis. It lasts 6 to 24 months. So 6 months to 2 years, you're gonna get treated for this disease. It's a very slow growing disease. It takes a long time to treat it. Okay, use at least 2 drugs. From a list of 11 that may work. So there's many strains of Mycobacterium tuberculosis. They are resistant to at least one of the drugs that commonly used. Most common treatment begins the initial phase of 4 drugs: INH, RIF, EMB, and PZA. Use all 4 drugs. You take it orally for 8 weeks. After that, continuous involves daily doses of INH and RIF for another 18 weeks. This is not an easy thing to get rid of. This is, like I said, 6 months to 2 years of treatment. A 1-pill regime is now being used, a Rifater, which combines the INH and the pyrimidine. Okay, and you can supplement the drugs if you need it. So tuberculosis is spread how? Contaminated fomites, food, respiratory droplets, or vectors. Vectors like mosquitoes or the live species.
Droplets, respiratory droplets.
Respiratory droplets, that is exactly how tuberculosis is spread. That's a nasty disease to try to fight. Okay, Mycobacterium leprae. Okay, this is gonna be leprosy. It's Hansen's bacillus or Hansen's disease. It's a strict parasite. Has not been grown on artificial media or tissue culture. Has to grow in the body in a cell. It's the slowest growing of all species. Multiplies with host cells in large packets called globi. Causes leprosy. Leprosy is a chronic disease that begins in the skin and your mucous membranes and progresses into the nerves. Endemic regions throughout the world. Mechanism of transmission is not fully verified. We don't quite have a full understanding of how it's transmitted. It's not highly virulent. It appears that healthy and living conditions influence susceptibility and the course of the disease. So healthy people can help prevent it, and the living conditions. Maybe it's supposed to be specific genetic markers of people who actually get the disease manifestations. Of course, infections and disease, macrophages, phagocytize the bacilli, but a weakened macrophage or slow T cell response may not kill it. Incubation is from 2 to 5 years. So they can sit in your bloodstream for 2 to 5 years. If untreated, it can grow slowly in the skin macrophages and the Schwann cells. Remember Schwann cells? Schwann cells produce myelin. Remember you have your nerves that run through here, and the nerve impulse travels down through this nerve, it propagates along it. Myelin coats these nerves and allow this transmission to occur hundreds of thousands of times faster. So it slows down the nerves and it damages your nerves, this disease, because if it does onto the Schwann cells. There's two forms, tuberculoid and lepromatous. Patients can have more than one form of leprosy simultaneously, and one type can progress into another. It's 2 to 5 years in there. So here's the one form is tuberculoid, and the other form is lepromatous, okay, which is multibacillary or paucibacillary. Okay, there's few bacilli in the lesions. There's many bacilli in the lesions. There's shallow skin lesions, numerous deep lesions. Loss of pain sensation, generalized, occurs late in the disease. Okay, so this is loss of sensation in the lesion. This is loss of sensation throughout the body. There's no skin nodules. There's gross skin nodules. There's occasional mutation of extremities, multiple mutation of extremities. Okay, it's reactive to lepramin. This is non-reactive to lepramin. Lepramin's extract leprosy with cells injected intradermally like tuberculin. It's detect delays allergy to leprosy. That's one of the treatments for it. Lymph nodes are not infiltrated by the bacilli in the tuberculoid form. Okay. Lymph nodes are massively infiltrated in the lepromatous form. Well-developed C-cell response, poorly developed T-cell response. So this is a much nastier form of leprosy. The tuberculoid leprosy, or the first form we talk about, is the most superficial form. Asymmetrical, shallow skin lesions. Lesions contain very few bacilli, produces dermal nerve damage, local loss of pain in the area. It does not go generally throughout the body. Forms with fewer complications, more easily treated than the other type of leprosy. And that's what it looks like on the bottom of the foot. This is how it spreads and causes deformation. Okay. The lepromatous form is the advanced form. You can have both forms at the same time, or the primary form can evolve into this one. Widespread dissemination of bacteria produce chronically and severe complications. Deep nodular infections cause severe disfigurement of the face and extremities. A lot of bacteria found in your skin scrapings correspond to the borderline lepromatous or lepromatous leprosy. And you can see the deformation that can occur. It spreads throughout the body, facial and extremities. Again, you can see the deformation occurring with advanced leprosy. Diagnosing it, combination of symptoms, microscope examination of the lesions, looking at bacteria, and patient history. Numbness in hands and feet, loss of heat and cold sensitivity, muscle, because your nerves aren't being propagated, are being transmitted. Okay. Muscle weakness, thickened earlobes, chronic stuffy nose. Detection of acid-fast bacilli in your skin lesions, nasal discharge, and tissue samples are how we diagnose leprosy. Treatment, long-term combined therapy, 2 to 5 years is this disease. Prevention requires constant surveillance of high-risk populations. No definitive vaccine for leprosy is currently available. Trials indicate that the bacilli commit with the leprosy bacilli, working on it with clinical trials. Okay. Infections by non-tuberculous mycobacteria, NTM, disseminated mycobacterial infected in AIDS, caused by Mycobacterium avium, complex bacilli, the third most common cause of death in AIDS patients. Mycobacterium avium complex. This is the bacilli, and it's the third most common death in your AIDS patients, that you're going to see. Non-tuberculous lung disease, Mycobacterium kansasi, causes pulmonary infection in adults, white males with emphysema or bronchitis as pre-existing conditions. Miscellaneous mycobacterial infections, Mycobacterial marinum, okay, is a water inhabitant. These develop after scraping, like on a scrape on a swimming pool, concrete. It's called fish tank granuloma. When you scrape yourself about like much of the mycobacterium lives marinium in water. M. scrophulaceum, infected cervical lymph nodes, and live in the Great Lakes region, Canada and Japan. And M. Paratuberculosis is very rare. It's for drinking raw cow's milk, was not pasteurized. Recover from 65 to individuals diagnosed with Crohn's disease. Okay, this is fish tank granuloma. You scrape the bottom of the swimming pools That's where the bacteria can affect the open wounds. Actinomycetes. They're non-motile filamentous rods related to mycobacterium. They may cause a chronic infection of skin and soft tissue. There's two main genera involved in human tissue, human diseases, actinomyces and nocardia. Actinomyces, Israeli, is responsible for infections of the oral cavity, thorax, and the intestines. Causes actinomyces. Actinomycosis, sorry, causes actinomycosis. Nocardia is Nocardia brucellensis, causes pulmonary diseases, similar to tuberculosis, causes nocardiosis. This is actinomyces. You can see it by the earlobe here, affecting the skin lesions. You can see the multiple skin lesions. Okay, so which of the following mycobacteria, mycobacilli, sorry, is responsible for the third most common cause of death in AIDS patients? Which would cause it?
Is it the M. paratuberculosis? Look, M. tuberculosis?
No,
No.
that one causes realize. Remember, it was the avium complex.
Oh,
Avium complex. It was right here. Disseminated microbacterial infection in AIDS caused by Mycobacterium avium complex. That's the third most common cause of death in your AIDS patients. That would be D. The Mycobacilli avium complex. This is one that affects your AIDS because they have a compromised immune system.